you very much for having me again with this next talk on COVID-19 and beyond. And it is a great pleasure to talk after my good friend Yati Mehta. And I am really sorry that we cannot share these moments together after the session and have a lovely Indian food and a good glass of wine. But this is how it is. And it's all because of this little bug called COVID-19. Okay, so let's see how the concept of blood purification and cytokine removal fits in this picture. So let me take you back without really going back into all the details, but let me take you back to this, one of my favorite figures from Didier Payen and co-workers, in which you can see the innate and adaptive immune response, which we can call the pro and the anti-inflammatory forces, which activate themselves when there is an insult, there is an injury, there is an infection, regardless whether it is trauma, surgery, viral infection, bacteria, fungi, whatever. And if we are healthy, then after being very ill, you have high temperature, you feel awful, you have aches and pains. If you are healthy, your immune system will get the situation under control and you will recover. Well, if you are, if the injury finds you in the wrong phase of your life, then this goes out of control and the patient will enter into a condition that we call nowadays as dysregulated immune response. We call it hyperinflammation, we call it cytokine storm. And these patients are in really in a life-threatening situation. So attenuating this burden of hyperinflammation with hemoadsorption certainly has some physiological rationale. And the device that we use, and this is a slide, has already been shown by Professor Mehta, that this, with cartridges like this one, like the Cytosoap, which includes some kind of components which are biocompatible, they have high absorption area, which in the case of Cytosoap is equivalent to 4 soccer or football pitches, as we call them in Europe. And they absorb molecules regardless within a range of anything up to 60 kilodalton, which is exactly the range for cytokines and inflammatory mediators. So it may have a rationale. And the first data came from animal experiments from, again, John Kellum's group from Pittsburgh. And what they did, they developed an animal experiment of cecum ligation and puncture, the so-called CLP model. And after 20 hours of the CLP, the animals developed septic shock, peritonitis. And then they randomized the animals into 2 groups. One of them was treated with the Cytosorb, and the other one was the control group. Now, dark columns represent the cytokine levels of the Cytosorb treated animals with septic shock, and the white columns are the control group. And you can see that after a few hours, after 3 hours, there was a significant difference, regardless whether it was pro or anti-inflammatory cytokines. So this is the animal background and the experimental rationale of using hemoadsorption and cytokine adsorption in septic shock. And this is our study, which was unfortunately just a proof of concept controlled study, pilot study. But we randomized 20 patients into 24-hour Cytosoap treatment versus 24-hour no Cytosoap treatment. And these were patients who were really ill with a very high vasopressor demand and elevated PCT on mechanical ventilation, very high severity scores. And what we found, that just one single 24-hour treatment of these patients resulted in a 70% decrease in vasopressor need, while there was no significant change in the control group. And procalcitonin also reduced dramatically, especially during the first 24 hours of Cytosoap therapy. So this was a preliminary data, and the strongest possibly evidence of the positive outcome we have so far is this retrospective propensity score match study from Rotterdam, from the Netherlands, in which they retrospectively evaluated the results of 100 and so patients treated with cytosorb compared to those who were only treated with CRRT but no cytosorb. So what they found was that the predicted mortality was higher in both groups. And in the cytosorb group, there was a more than 25% reduction in the actual mortality, in the observed mortality as compared to the predicted. And when they performed a thing called, it is a stabilized inverse proportional treatment weight analysis. So they basically balanced out the groups. They created a dummy group from the control arm, which was as severely ill as the cytosorb arm, and then they evaluated the outcomes. Then it revealed an almost 20% reduction in the cytosorb treated patients as compared to controls. So what we have so far are positive signals of case series, case reports, retrospective data, and prospective small studies. And it may also improve survival in addition to reducing the circulating level of serum cytokines. Now, what about COVID-19 patients? Well, this is a figure I took from the company, which this is an old figure, but this is very nice because it depicts that cytokine removal is not within the domain of sepsis only. You can use it for burns, surgery, trauma, and of course you can use it for influenza and the most dreaded complication, ARDS in COVID-19. So this all falls within the possible indications of cytokine removal. And don't forget that removing of cytokines aims to regain control between the pro and the anti-inflammatory forces, to regain balance and to treat the imbalance between those two equally important forces. Now, what happens in COVID-19 is very nicely depicted in this paper by Tai and co-workers, published a couple of months ago. And it is a nice summary of the trinity of COVID-19. And it's all about immunity, inflammation, and intervention. This is the trinity. And what you can see here on the first figure is that our immune system can protect us via several measures from the virus. It can clear it from the lungs, no problems. If a cell becomes infected, there is cellular immunity. So in other words, about 80% of the population will sail through COVID-19 without any major symptoms. However, there is a minority of patients who get infected, and then they develop the dysregulated immune response. And due to this, the host immune response can overwhelm anti-inflammation, and then these patients can develop all the symptoms that are very similar to septic shock, including systemic cytokine storm, pulmonary edema due to increased capillary leakage in the lungs, and widespread inflammation and multiple system organ failure. And the same authors in the same article also depict several possible interventions via which we can potentially handle the injury and the insult. And one of them is mechanical removal of the circulating cytokines. And the authors go as far as they suggest that controlling inflammation may be as important as targeting the virus. A very new concept. I really like this concept. And this was also emphasized very early during the COVID-19 pandemic by Claudio Ronco, Jean-Louis Vincent, Paolo Navalesi in a point of view paper, in which they emphasize that new extracorporeal organ support therapies, including chemoadsorption and hemoperfusion, designed to remove cytokines and other circulatory mediators should be considered. So without any clear evidence, the pathophysiological rationale is there. And we have mounting data, at least, to support that some patients do benefit from these approaches. So possibly this is the reason why the FDA gave emergency use application in these patient group for hemoadsorption with cytosorb, and also in India you have an approval to use extracorporeal blood purification. But it's not only the US and India. There is the World Health Organization, China, Colombia, Italy, Panama, Great Britain, Germany, Israel. It is a written concept recommendation that you can reach out for this technology and therapeutic modality in these patients. And physicians started to use it. And this is a case series, 3 cases from the United States. And I am not going to show you the video, but if you click on this link from my presentation, you can watch the full video that is presented by Dr. Lucian Durham. And he was interviewed on American television. And he treated patients with severe COVID-19 caused ARDS and ECMO. And these patients in southern Wisconsin were recovering after the treatment. They had very good experiences. So the therapy is gaining ground all over the world. And especially in the most severely ill patients with acute respiratory failure who require extracorporeal membrane oxygenation. It was shown in this very recent study when they compared 13 cytosob treated patients to 7 control patients. Again, retrospective study, case match. So it's not a prospective randomized study, but you can see a very nice pattern of decreasing PCT levels and decreasing norepinephrine requirement, whilst it wasn't as dramatic or non-significant at all in the control group. And they concluded that cytosob in combination with the ECMO is an effective alternative therapy. Then this is some preliminary data from Germany, from Alexander Supadi's group, which was just recently published in Critical Care. And they are planning large studies, but this is a preliminary study indicating that those patients admitted to the ICU with COVID-19 requiring ECMO and were treated with cytokine absorption, they had a dramatical decrease in IL-6 levels as compared to those patients who were not treated with cytokine absorption. So based on these observations, there are several studies now published on clinicaltrials.gov. This is one of them, the Cytokine-19 study that was just recently reported on the ESICM virtual conference last week by my good friend from Hamburg, Axel Nierhaus, sorry, and Axel depicted the details of the trial, which is published now on clinicaltrials.gov. And they look into patients with pneumonia due to COVID-19. And of course, these patients has to be hemodynamically unstable, moderately elevated cytokine levels, and indication the need of a extracorporeal renal replacement therapy. And the primary endpoint is shock reversal. So we'll see the studies ongoing. And we started a registry, a Cyto8 registry, to include patients who are treated with cytosorb after admitted to the ICU due to COVID-19 acute respiratory failure. All we want is a prospective observational study. So it is open for anyone who is willing to join. It has EC approval. It's on clinicaltrials.gov. And now we are planning to publish the pre-study protocol in trials. So in summary, there are several potential indications for cytosorb in COVID-19 patients. There is an immense interest and activity worldwide, and the research activity is also detectable if you just punch in clinicaltrials.gov. You can see how many studies are up and going. And beyond just a few slides, what is going on beyond COVID-19 and what is novelty? Well, we have the biggest case series in a format of a registry, the cytosorb registry. Almost 1,000 patients were analyzed, and now we have more than 1,000 patients in the registry. And we have submitted the revised version of the first analysis of these 930 patients to critical care. So hopefully it will go through the evaluation process. And what we found was that the treatment found to be safe by the doctors. It significantly improved cardiovascular and pulmonary function. It reduced the levels of routinely measured cytokines. and may have a potential benefit in the highest risk patients. And the physician satisfaction was very high, above 70% regarding the therapy. We also performed a subgroup analysis of those patients who were treated with CytoSorb for acute liver failure within this registry. And CytoSorb has two potential indications in acute liver failure. On the one hand, it protects the organism from the liver-produced cytokines. On the other hand, it can produce the liver. It can prevent the liver from the circulating cytokines. So we found very positive results. Again, the manuscript is under preparation. So, well, these are preliminary conclusions. What we found that it was the third most frequent indication. It removed bilirubin effectively, and there was a very high physician satisfaction rate as depicted by that they observed improvement in the patient's condition. So this is my last slide, and there are more than 100,000 treatments worldwide. And as you can see, since August 2015, when the whole story started to be big, really, there is an immense improvement on all fronts. There are a lot of publications, a lot of ongoing studies. So you have two options, I think. And just as Professor Ronco depicted, and also Professor Mehta, that you have two options. One is you sit tight and wait for the evidence, or you can generate the evidence. And obviously, as a researcher, I do belong to the latter group. So I'd rather try to generate evidence and create data and produce studies rather than just sit and wait. So if you feel so, then please join the CytoSorb experience. Thank you very much.